Welcome to Issues and Answers. I'm Cheryl Harleston. Today we're going to be talking about breast reconstruction and the wonderful, marvelous things that are happening in that area. There are options for reconstruction these days, and women and their spouses or loved ones need to know what's going on in this field. We're going to talk about that with a gentleman who knows a lot about it. So please stay with us. We'll be right. As mentioned earlier, we're going to be talking about breast reconstruction, and a lot of interesting things in that area are going on in the Charleston community, and people from all over the country are coming to see various physicians who have really tackled this thing and have discovered ways to make women look beautiful again, especially after cancer. And my guest today is Dr. Richard Kline, and he is in private practice. However, he has a relationship with several hospitals in the area. And I'd like to welcome you to our program. Welcome.
Thank you.
It's so nice having you here. And your area of work is precious to women. We're talking about Cancer Awareness Month and lots of activities going on in that area to educate us. And I want you to educate us today on what we can do, women can do when we have breast cancer. Basically, what is breast reconstruction? What's meant by that?
Breast reconstruction means trying to restore as much as we can with today's technology the breast that the woman lost due to cancer.
Now, you're a plastic surgeon, is that
Yes, ma'am.
your title? So something else was going on in the past, and there are new techniques now. What was the old way of trying to put a woman's breast back together again so that she could function as normal as possible?
Well, there's basically two big schools of thought or ways to reconstruct a breast, and the big difference is one involves using implants. They're usually the same implants we use for breast augmentation. We can use them for reconstruction, and that's still a perfectly good option for a lot of women. In fact, the majority of women have reconstruction using implants.
Now, the implants are what? They're made out of various kinds of material.
The shell is a silicone elastomer, which
Yes.
is fairly firm, and they can either be filled with modern silicone gel, which isn't like the old gel, which was runny and yucky. The new gel is called cohesive gel. And you can actually cut the implant with a knife, and the consistency is sort of like silly putty. It doesn't run anywhere, and we're all very hopeful that these are going to be much more reliable than the old implants.
How does the body handle something foreign being placed in the area where the breast once was? Is that working out okay?
Well, silicone is a very inert thing. It's in a myriad of medical devices, and there's really, I think, no way we could not have silicone in our bodies. But the problem with breast implants used in reconstruction for some women is that their body internally will lay down layers of scar against the implant for reasons no one fully understands. And it can make the breast hard, occasionally make the breast painful, and some women simply are not able to achieve a satisfactory reconstruction using implants for that reason or other reasons. Sometimes people get infected with breast implants. And if you have radiation as part of your cancer treatment, it greatly increases the difficulty in getting a successful implant reconstruction.
Is it possible, and I'm going to get into the option here directly, but I want to make sure everybody understands what has been done and what's currently going on. I mean, this is still happening. We're having reconstruction, and we're having these implants placed in, whether they be silicone or what have you.
Right.
And it's still, but have you found that more and more women, I'm curious about the rate of cancer, and I'm not going to ask you what that rate is, but I'm curious about the number of women you're seeing today that requires some sort of reconstruction. Is it true that cancer, and I know this is not your area, the oncologist knows that, but is it true that you see a lot or a number of women in the same family?
Yeah, I think physicians have recognized for a long time that there are certain families where you get clusters of patients having breast cancer, sometimes, 20 years earlier than you would expect. And within the last few years, there's been some genes identified, the BRCA genes, that we know now, if you have the gene, you have a greatly increased risk of developing breast cancer during your lifetime.
Is there a test that can discover that?
Oh,
these
there
days?
are tests, and your primary care provider or obstetrician or breast surgeon could certainly, or a geneticist could have you get those tests. Interestingly, there are ladies who have a very high family history, strong history of breast cancer who don't test positive for these genes. So there's a lot of thinking that there may be other genes out there that do the same thing that just haven't been discovered yet.
The kind of, for me, I hadn't heard of it before, but it's kind of a new way for me to reconstruct the breast. And you told me about flaps and other types of ways, material taken from the stomach area,
Right.
from the buttocks. Talk to us about what is involved in this option for women as opposed to surgery that they once had. They now can use this form of reconstruction.
Going back to our earlier topic, so breast implants are one way of reconstructing breasts. Another way is to use your body's own extra tissue. And a lot of patients have extra tissue in the tummy area, particularly if they've had children. Some people have extra tissue actually more in the buttock area than the abdomen. In the 1980s, a technique was developed to use that extra tummy tissue to make a breast. Unfortunately, it involves sacrificing the rectus abdominis muscle, which is the weightlifter's six-pack on his tummy, if you will, and it was used to passively carry blood to the tissue that was used for the breast reconstruction. And if you needed both breasts reconstructed, you lost both of those muscles. And a lot of people tolerate that very well, but I think everyone agreed it would be better if you did not have to use those muscles. They're fairly big, they seem fairly important, they let you pull yourself forward directly. So surgery evolved, and people found a way to take the tissue first just with a little piece of muscle. Now, since we left most of the muscle there, that means the tissue had to be taken completely free of the body and put up in the breast area, and you'd use a microscope to sew blood vessels together.
Now, is this surgery all done at the same, both surgeries, or both cutting and placing? Is that done all at the same time? Is it necessary to once you remove that skin at the stomach area or the buttocks area, that you've got to get it right to the patient?
It needs to go during the same anesthetic. But the surgery that we actually are focused on was developed by Dr. Robert Allen at LSU. He's actually a Florence, South Carolina native. He found out that you don't need to take any of that muscle. You can take the skin and the fat and extract the blood vessels and move the skin and the fat, which is all you need, up to the mastectomy area, sew the blood vessels together, and it works fine. And that was a huge, huge breakthrough.
That was a huge, and we want to talk more about that, because I understand that you knew this gentleman, the doctor that you're talking about from Florence, and I don't know if you did your residency with him or...
I actually did. He was my residency director.
Okay.
I had the privilege of watching him develop these techniques, and I finished my residency in '93 and was New Orleans' first full-time plastics faculty, and had the pleasure of practicing with him as he developed it further. And
Is he still with us?
He is. He's largely relocated to Manhattan.
The New Yorkers need him.
I operated with him here in Charleston about a month or two ago. We still keep in close contact.
When we come back from the break, I'm interested in the number of women that know about this. I mean, is it just common knowledge, or are we having to discover it? We're going to do that in just a moment when we come back from the break. We'll be right back. We're going to find out how many women know about this, or is it a well-kept secret? Welcome back to our program. I'm talking with Dr. Richard Kline, and he is involved in a way of making women's breasts look natural and healthy, and it's natural. I think the word that they're using in this practice is natural, and it really does seem to be natural, I tell you, because as you were saying to us before the break, you're taking portions of the woman's stomach or her buttocks, and you're using that to reconstruct a breast, or several, or both breasts at times. Are you finding that most women, or is it common knowledge that this kind of reconstruction is taking place, and it may be an option for you?
Well, if you start looking for this, it pops up pretty quickly on the internet. But interestingly, fairly recently, there was a paper published in a medical journal that showed that only about 1/3 of women who are diagnosed with breast cancer even have reconstruction discussed, even brought up to them. And
oh, really?
we're not sure what all the reasons are for that. So no, it's not common knowledge.
Is it something that, do you think it's something that women just give up and say, I'm not going to put anything foreign or different on my body. I don't have my own breast, so that's it?
Well, I'm not sure why the breast reconstruction isn't even discussed, but when breast reconstruction is discussed, the most typical thing a woman would be offered would be an implant.
Dr. Kline, where can we find this information?
Well, it's all over the internet. You could look on our website. You can just search the actual name for the stomach tissue when transferred like this is DIEP. That's an acronym for deep inferior epigastric perforator flap.
Wow, that's a mouthful.
We also use the buttock, and we call those gap flaps. That's an acronym for gluteal artery perforator flap.
And that's your glutamax back there.
Yeah, the glutamax.
That's
there you
right.
go.
Which is easiest?
The stomach, while difficult, is considerably easier than using the buttocks. If you use the buttocks, you have to flip the patient twice on the operating table. It takes a very specialized team to do that. In fact, there's very, very few places you can reliably, if you need both breasts reconstructed, have them both reconstructed from the buttocks at the same time.
Is that how is the decision made that we're going to go to the stomach for the skin or the flap as opposed to the buttocks?
Well,
is it just when you're having double?
Well, we usually, that's a complex question, but as a general rule, if you've got adequate abdominal tissue, we recommend that you use it just because it's easier and you don't have to go through those position changes on the operating table.
And about how much of the skin is taken and the muscle is taken along with it?
No, we never never take any muscle.
Okay.
Never take muscle.
So then in the past, when it was difficult to bow and so forth, that's not happening now because you're not using the muscle in the six-pack area.
We believe that our patients tolerate it much better than when they had the muscle taken. Back when I used to do the surgery, taking the muscle, I had patients complain of pain 6 months after surgery, and now some of them quit complaining of pain several days after. Not everyone, but we think it's much better tolerated.
And what else? You're taking out the skin and also, not the muscle anymore, but the fat. How about veins and that kind of thing? And do you have to reattach those?
We need to take out at least one artery and vein, and we use a microscope to hook that up to an artery and vein in the mastectomy area so that the new tissue will have blood flowing to it.
And is that instant? The blood flows instantly?
It is.
And how long does that surgery take?
To reconstruct one breast, usually it takes us 4 to 6 hours. To reconstruct 2 breasts, it's usually 6 to 8 hours.
Is this something that most insurance companies take care of for you?
They have to. By law, there's a federal law passed in 1998 that requires insurance companies to pay for it. Some pay more than others, and that can make it difficult sometimes.
Women are choosing this option more and more. Apparently the word is getting around to such an extent that you're getting women from all over the country.
We are. We have a long track record. When I moved here from New Orleans in 1996 and brought this to the Charleston area, I think I probably did the first flap of this type in 1997 in this area. We now have women coming from all over the country. We're up to about 800 flaps between Dr. James Craigie, who's my partner, and myself. Our flap survival rate's about 99%. In the last year, we've had ladies come from California, Utah, Colorado, Ohio, Missouri, and of course a lot more from the surrounding states.
Now, after the treatment after the surgery, does the woman, especially if they've come that far, do they just stay in the area?
Right.
Or do they return home? And
it's a pretty well worked out routine. We typically keep them in the hospital 4 days, although some stay longer for various reasons. We ask that they stay in the Charleston area for at least a full week after surgery, and most of them by then are ready to go home. If they have a physician in their local community who can help with their care, that's obviously a big plus, and most of them do have someone who can help.
And you would be able to refer them because you know of doctors in many parts of the country?
Absolutely.
Yeah.
And we're actually referred a lot of patients by plastic surgeons who don't do this procedure, and that's just ideal because then we can communicate with them.
Is there some sort of organization or some way that where doctors communicate with one another so that this information can be much more widespread than what it is? Is that happening, do you think?
Well, there's a lot of interest in getting it out there. I think the most positive thing is there's a huge amount of information on the internet about this, on discussion boards and various websites. There's, if you go looking to see what's the best breast reconstruction you can get, looking on the internet, there's no way you can miss discovering this kind of surgery.
Is the implant any way different from this approach, the natural approach, or taking the flap and putting it, making a breast?
There's nothing wrong with implants for most people, and I don't want to knock implant reconstruction at all. There's been many beautiful implant reconstructions, and my goal is not to make anyone unhappy who previously thought they were happy with their implant reconstruction. This surgery that we do sort of originated for people who had problems with implant reconstruction. As I mentioned, people who are radiated have a terrible time getting a good implant reconstruction. Some people had gotten infections with implants and just didn't want to go through it again. And for those people, this surgery was often their only hope, and many of those have been helped. What we see more and more of is women just saying, I just don't want an implant in my body. And we're sympathetic to that. I mean, I personally think a breast made with your own tissue that's warm with blood flowing through it is something that down the road will cause you less trouble. And there's studies that suggest women accept breasts as their own if they're made with their own tissue more than implants. But it is a bigger surgery to go through. It's not for absolutely everyone, although we operate on a wide range of ladies. Many ladies in their 70s have been some of our best patients.
Wow. And I'm wondering, we need to go to the break right now, but I'm wondering, how do you take a piece of skin from the stomach, or a flap as you call it, or from the buttocks, which are the two places, and shape it so that it now looks like or feels like, and I don't know if it feels like a breast or not, but we're going to find out in just a second when you come back and we come back. We'll be back in just a moment. Want to know how they shape these breasts once they remove the skin from some other place, and how does that look in your clothes? We'll do that in a moment. We're talking about breasts and how those breasts have options when a woman has cancer and she wants reconstruction, or she can have an implant, and there are many ways to make us look beautiful again. And before we went to the break, and I'd like to reintroduce my guest, who's Dr. Richard Kline. He has a practice in this community, and women are coming from all over the country to get your services. Tell me about the woman from Colorado.
That was a particularly satisfying case. This was a lady in her 30s who had had breast cancer and was radiated on one side, had had her implants become infected, had lost them. She recognized that maybe using her own tissue might be an option, but really didn't have enough tissue in her stomach to reconstruct both breasts, and for about 5 years just lived thinking she would never have any breasts. And she heard about us and found that we're one of the, it's probably about 3 practices in the country that routinely every day, not every day, but many days, reconstruct both breasts at the same time using your buttocks. So she flew here from Colorado and we reconstructed her, and everything went very, very well, and she tells us it's changed her life, and that's why we're here. That makes us
bet
happy.
there are a lot of stories like that. If we were to interview women who come out of your office, out of the hospital, or wherever you are, I bet we hear a lot of those kinds of stories about women who are satisfied. But I'm curious about something, and that's the shaping. I mean, because our breasts do have a certain shape, and I'm visualizing somehow that this skin that's removed is sort of flat.
Well, it's
and I can't imagine it getting shape.
Everyone's different. Some people are flatter, some people are thicker, and every mastectomy is different. Sometimes the mastectomy surgeon saves a lot of skin, sometimes he saves the nipple, sometimes he doesn't. But in the beginning, we don't try to shape the breast too much. We transfer the tissue and make sure the blood vessels, which are very delicate, are open, and then we just leave it alone. And I tell patients it's like we're throwing 2 lumps of clay up there trying to get them to stick. Several months down the road, 3 months or later, we go back and we do what's called the second stage. At that point, we just shape the breast. We listen to the patient's requests. We try to change the size if she wants them changed. We change the shape. We revise the donor site, the stomach. We do everything we can to make you, from here to here, collarbone to hips, look like a supermodel. And that's when all the shaping is done.
What's inside of that breast at that point that allows you to shape it? You know, with the transplant, we know. I mean, it's a foreign object, silicone or whatever. But what's inside of the natural skin that allows a breast to be shaped from something, a piece of flap or a flap coming from the stomach?
It's just fat.
So you're placing the fat in there, or do we just get, or do you tell us not to go on a diet and get fatter?
We move all the extra fat from the other place, from the tummy or the buttocks. And the fat that you don't want down there is the best thing that there is to make breast out of.
And then you get a tummy tuck at the same time. Not really, but
that can be part of the attraction.
Yeah,
right.
Yeah, but it works. And you have more and more women who are coming and they're getting this surgery.
There's no question the popularity is increasing all the time. More surgeons are learning how to do it. It's going to become the gold standard as more and more people learn to do it.
But you're doing implants at the same time.
We still do breast implants.
Right. Does the woman, when you talk to your patients, do you say, here are 2 ways that you can do this, or do you give them a choice? Or do you look at the circumstances?
Well, for some people, implants are going to be a better choice for one reason or another, and I would try to push them into it. I make sure everyone's aware that they have 2 options, because I just think that's part of being fair. But the majority of the women who find their way to our office have already made up their mind. They're there to get one of these flaps. They don't want implants, and I don't waste their time trying to talk them out of flaps if they're otherwise a good candidate.
So as women, we don't need to give up. We can have our bodies look almost the way they did, perfect, in my sight.
This is the bottom line. Irrespective of scars, and you will have scars after breast cancer and reconstruction, our goal is to have your body shape be better than when we're through with you than it was before you got cancer. And my estimate is probably almost 75% of the time we get there.
This has been great information, Dr. Kline, and we appreciate you being with us today.
Thank you for inviting me.
You're quite welcome, and giving women hope that they can look the same even after going through such a dreaded disease, cancer. Well, we've been talking about the fact that breast reconstruction is available to you in this community, and for women who are facing this kind of thing, we encourage you to use the information that you see on the screen right now so that you can get additional information once you've decided what you need to do. And I'm sure that Dr. Kline and his partner will confer with you and give you the information that you need, so use it. As far as Issues and Answers is concerned, we always enjoy having you contact us, and we'll do a program that may be of direct interest to you. So get in touch with us, and there's the information on the screen so that you can contact us. Well, there you have it. Issues and Answers. I'm Cheryl Harleston.